In this presentation, we are going to focus not specifically on the critically ill patient or the med-surg overflow patient, the post-op patient, but rather the veteran. By a raise of hands, who here has served, currently serves, or has a family member who has served in the military? Here is the objectives for this presentation. There is quite a bit of content, and I will not be going into a lot of detail because these are very complex topics. This is an introduction to the topic of veteran-centric care. We will be discussing the VA mission and VA healthcare, defining veteran-centric care and veteran-informed care. Review what veteran culture is and what veterans want you to know about them. We will discuss building trust with cultural competence, then lead into the various military conflicts and the implications to the veterans who served in these conflicts. We will skim over service connections and disability ratings, then discuss the healthcare impacts of military service on veterans. The physical and mental health considerations. I will introduce trauma-informed care and discuss resiliency in veterans, and close with a call to action. To begin, let's talk about what makes the VA different. The VA's foundation is unique. It wasn't built to compete in the healthcare marketplace. It was built to fulfill a national promise. Its purpose is service, not profit. Every policy, every care decision is grounded in that commitment. The VA's values mirror the values of the people it serves: duty, sacrifice, and commitment. The VA's mission originally came from Abraham Lincoln's second inaugural address. In 1959, it was adopted officially: to care for him who shall have borne the battle, and for his widow and his orphan. And in 2023, the VA Secretary updated the mission to reflect a more inclusive approach. To fulfill President Lincoln's promise to care for those who have served in our nation's military and for their families, caregivers, and survivors. This updated mission shows the VA's continued dedication to not just veterans, but also the people who support them. This matters because it shapes how we show up every day. At the VA, we're not driven by numbers or quotas, we're driven by purpose. That shared mission bond staff motivates us and reminds us why we're here: to care for veterans, no matter what. This is what truly sets the VA apart. It's not just about care, it's about honoring a commitment, a continuation of the military's promise to never leave anyone behind. We'll explore this idea more deeply when we get into veteran culture, because this mindset, this bond, is at the very core of how veterans view trust, loyalty, and care. Every nurse, doctor, administrator, and employee at the VA is a part of that mission. That's why working here is more than just a job. It's a duty, and it's an honor. Remember, we are here because they served. Veteran care is a specialty because it involves unique health conditions, military cultural factors, and navigating complex VA systems. Veterans often face issues like toxic exposures, combat injuries, and service-related mental health needs. Providers also need to understand reintegration challenges like identity loss, unemployment, and homelessness. This is why culturally competent, holistic care is so important, and why more nursing programs are including veteran-centric content. The University of Colorado, for example, offers a certificate, master's, and doctoral program focused on military and veteran healthcare. Quick show of hands, who's heard the terms veteran-centric care or veteran-informed care? Veteran-centric care means delivering care that respects and integrates a veteran's unique experiences and values. It's about cultural competence specific to the military community. Veteran-informed care goes a step further. It means recognizing how military service impacts health and using that understanding to guide your clinical decisions and interventions. Here is two examples to demonstrate the difference. A veteran comes into the ED with severe abdominal pain. They appear guarded and are reluctant to answer open-ended questions. In veteran-informed care, the provider recognizes that this veteran may have been exposed to burn pits during deployment, which can be linked to chronic GI issues. They consider this in their assessment and ask about deployment history and exposures. With veteran-centric care, the provider also understands the veteran's communication style: direct, mission-oriented, and respectful of hierarchy. They use clear, concise language, offer a straightforward plan of care, and build trust by acknowledging the veteran's service. For example, "You've been through a lot. We're here to take care of you the way you deserve." Both are essential if we want to truly meet veterans where they are. Being culturally competent means recognizing that every patient brings their own background, values, and communication styles into the room, and for veterans, that includes a very specific military culture. Military service shapes how veterans view authority, seek help, and respond to care. So, to build trust and truly connect, we have to understand that culture and act as a bridge between civilian and military worlds. Culture can show up in many ways: national culture, workplace or organizational culture, military culture, rooted in discipline, duty, and chain of command, and even our own healthcare culture, like in critical care, fast paced, no nonsense, high accountability. So think about this. What cultures do you identify with? If I told you your patient is a police officer or a firefighter, what does that tell you about how they might think or communicate? And what about us? Critical care nurses, we have our own culture too. Direct, focused, adrenaline driven. Now imagine bringing those two cultures together, military and critical care. That's why cultural competence matters. Veteran culture is more than just military service, it's a lifelong identity. Healthcare providers who understand and respect this will build trust and provide better care. To better understand military culture, I've broken it down into 5 key elements, listed here on the left. These are areas where culture shows up in everyday life, and on the right, we see how each one applies specifically to veterans and service members. Values and beliefs. At the core of military culture is honor, duty, and sacrifice. Veterans are trained to put service before self. They adopt a mission-first mindset, goal-oriented, disciplined, and resilient. That self-reliance we admire? It can also mean that asking for help feels like weakness. Traditions and rituals. There's a strong sense of camaraderie, deep bonds formed through shared service. Veterans are used to hierarchy and clear chains of command, and they take pride in uniformity, discipline, and professionalism. Language and communication. Veterans tend to be very direct, clear, and concise. They use acronyms and jargon that may not mean anything to civilians. Open-ended questions can feel confusing or vague. They're used to getting clear, mission-focused instructions. Symbols and identity. Branch of service, rank, and deployments help shape a veteran's identity. Unit patches, medals, and uniforms carry meaning and pride. And it's not just the veteran. Military families share in that identity through sacrifice and support. Social structures. Veterans often operate with a team-oriented mindset, accountability, and responsibility to others. Many have an always-on-duty mentality, which can lead to hypervigilance and difficulty relaxing. Reintegration into civilian life can feel isolating. So, as healthcare providers, when we understand these cultural pieces, we're better equipped to build trust, deliver meaningful care, and bridge the gap between civilian and military worlds. This information was gathered by Navy psychologist Dr. Heidi Kraft, who asked veterans one question. What's the one thing you'd want your doctor, nurse, or therapist to know about you? These answers are powerful reminders that veterans are not a monolith, and understanding them requires effort, empathy, and cultural humility. Not all are soldiers. There are 6 branches, each with their own roles, cultures, and values. There are 2 ways to serve: active duty and reserve. Each comes with its own stressors. And not everyone was infantry. Many served in support roles: medical, aviation, logistics, intelligence, and more. Combat exposures can extend to all roles, but not all service members see combat. Veterans are held to high standards of discipline, accountability, and appearance, often from day one. And the always-on-duty mindset doesn't switch off after discharge. Not all have PTSD. Not all have killed. And even those who have don't want to talk about it. Invisible wounds like TBI and moral injury are real, and they don't always show. Asking for help is hard for many veterans. Service teaches self-reliance, and vulnerability can feel foreign. Military service changes people, and how veterans choose to identify with that part of their life varies. Some embrace it, others distance from it. We also have to remember, the family serves too. Spouses, children, they carry the emotional weight of service as well. Ultimately, the one message that comes through clearly is this: Veterans chose to serve something bigger than themselves, a mission, a country, a team. They were willing to die for each other, to die for their country. And that sense of purpose shapes who they are, long after the uniform comes off. These insights and more are explored in short videos and over 250 free online courses at psycharmer.org, an excellent resource for anyone caring for veterans. Sometimes, a patient's military service is the elephant in the room. We know it's there, but we don't always ask about it. Acknowledging that part of their life is essential to building trust. Simple questions like, what branch did you serve in? What was your job? Where were you stationed? Did you enjoy your service? These aren't just icebreakers, they're trust builders. They show respect. They tell the veteran, I see you. Recognizing and respecting military culture not only improves communication, it improves care. And always thank them. We are here because they served. This timeline highlights major U.S. military conflicts and the current age range of veterans who may have served in them as of 2025. Knowing when a veteran served gives us critical context. Each era brings its own exposures, stressors, and health risks, from Agent Orange in Vietnam to burn pits in Iraq and Afghanistan. It also helps us understand what psychological or emotional impacts a veteran may carry, whether that's combat trauma, survivor's guilt, or the challenge of reintegration. And let's not forget our peacetime veterans. Even without combat, their service shaped them. Long deployments, military culture, and separation from family all leave a mark. Veteran-centered care starts with understanding their era of service, because that shapes not just their history, but their health and how they experience care today. I won't be diving deep into each conflict individually, but it's important to recognize that every era of service comes with its own unique exposures, health risks, and mental health impacts, in addition to those tied to military service in general. For our World War II veterans, key exposures included radiation, hearing loss, cold weather injuries, and what we now recognize as PTSD, then called battle fatigue. Mentally, many carried delayed PTSD symptoms and survivor's guilt for decades. From a service connection standpoint, radiation exposure and being a former prisoner of war come with specific presumptive conditions that can impact benefits and care eligibility today, even as these veterans enter late life or hospice. For Korean War veterans, key exposures and health risks included extreme cold injuries like frostbite and trench foot, along with hearing loss and early signs of combat stress. Mental health considerations often involve delayed PTSD symptoms and untreated trauma, especially in a generation that was less likely to seek help. Service connections include presumptive conditions related to cold injuries and specific benefits for former prisoners of war. These veterans are now among our oldest, and their military experiences may still shape how they view care, trust providers, and express symptoms. For Vietnam-era veterans, key exposures and health risks include Agent Orange exposure, infectious diseases like malaria, and long-term impacts from guerrilla warfare environments. Mental health considerations often include PTSD, moral injury, and complicated reintegration experiences, especially with how they were received upon returning home. Service connections are strongly tied to Agent Orange presumptives, including several cancers, diabetes, and ischemic heart disease. Many Vietnam veterans avoided seeking care for years due to stigma or distrust. Understanding their service history helps us rebuild that trust and connect them to the benefits they've earned. Gulf War veterans face a unique set of challenges tied to their era of service. Key exposures and health risks include oil fire smoke, depleted uranium, anthrax vaccines, and what's often referred to as Gulf War illness, a multi-symptom, chronic condition. Mental health considerations include PTSD, chronic fatigue, and depression, sometimes complicated by the lack of visible injury. Service connections include a list of unexplained chronic symptoms that are presumptively covered under the Gulf War regulation. These veterans are often in their 50s and 60s today, and many are still seeking validation for symptoms that were initially dismissed. Veterans from these most recent conflicts represent a broad age range and come with both visible and invisible wounds. Key exposures and health risks include IED blasts, burn pit exposure, musculoskeletal injuries from repeated deployments, and mild traumatic brain injury. Mental health considerations are wide-ranging. PTSD, anxiety, depression, and moral injury are common, as are adjustment challenges after multiple tours. Service connections include burn pit-related conditions, now presumptive under the PACT Act, TBI, and PTSD. These veterans may still be navigating reintegration, identity shifts, and barriers to accessing care. They're also more likely to use VA services if we meet them with understanding, flexibility, and cultural competence. Veteran-centered care also means acknowledging those who served during peacetime or in non-combat roles because their service still carried risks and lasting impacts. For general service or peacetime veterans, key exposures and health risks often include training-related injuries, hearing loss, military sexual trauma, and significant identity or reintegration challenges after leaving the service. Mental health considerations may involve adjustment disorders, identity loss, underrecognized PTSD, and MST, especially when their service experience feels dismissed due to the absence of combat. Service connections can be more difficult to establish. Many of these veterans struggle to get recognition for MST, training injuries, or emotional trauma, despite how real and lasting those impacts are. Every veteran has a story, combat or not, and acknowledging their service is the first step in providing equitable, compassionate care. The PACT Act is a game changer. Passed in 2022, it's the biggest expansion of veteran benefits in decades. It added over 300 conditions to the list of presumptives, meaning veterans exposed to burn pits, Agent Orange, or other toxins no longer have to prove the connection. The assumption is in their favor. This matters because it opens the door to care and compensation for millions of veterans who were previously denied. It applies to veterans from Vietnam to Iraq and Afghanistan, and it's already impacting lives. If you care for veterans, this matters. And if a veteran you're caring for doesn't know about it, this is your opportunity to connect them to support. This isn't something you need to fully understand to be veteran-centric, but many nurses find it helpful. First, a quick reminder. The VHA, that's us, the healthcare side, and the VBA, which handles benefits and ratings, are two entirely different branches. And they don't always communicate as smoothly as we'd like. We're not going to dive into who qualifies for what, because that's not the goal today, and honestly, it's incredibly complex. But here's the basic idea. Veterans, like anyone else, can develop illnesses or injuries. But if that condition can be connected to their military service, directly, through aggravation of a pre-existing condition, or as a secondary result, it may be service-connected. More recently, some conditions are considered presumptive, meaning the VA assumes the condition is related to service without requiring full proof, like ALS, Agent Orange-linked conditions, or burn pit exposure. Once a condition is claimed and determined to be service-connected, it's assigned a disability rating from 0% to 100% based on how disabling it is. Now here's where it gets tricky, VA math. Ratings aren't just added up. For example, a 50%, 30%, and 20% rating doesn't equal 100%, it might equal 70% total disability. So what's the takeaway for nurses? It's not your job to understand the whole claims process, but you can play a big role by encouraging your veteran patients to explore their benefits. If they haven't connected with a veteran service organization like the DAV, American Legion, or VFW, help point them in that direction. New presumptive conditions are being recognized all the time, especially from more recent conflicts, so supporting your veterans in this area could truly change their lives. Military service impacts health in ways we often don't fully recognize. Service-related injuries are common, whether it's from repetitive stress, intense training, chemical exposures, or trauma. Chronic pain, PTSD, and respiratory illnesses from burn pits or Agent Orange are just a few examples. Veterans face higher rates of chronic illness, traumatic brain injury, musculoskeletal injury, and mental health conditions. Another important piece? Many veterans delay seeking care. That mission-first mindset runs deep. By the time they do seek help, their needs are often complex and layered. Add to that the challenge of navigating the VA system, eligibility rules, disability ratings, service connections, and many veterans end up caught between VA and civilian care, with little continuity or clarity. That's why military cultural competency matters. and why we need veteran-centric models like whole health and the PACT model. When we understand how service shapes health and care seeking, we're better prepared to deliver the care our veterans deserve. When we think about veteran mental health, we often start with PTSD, but there's a much wider range of concerns we need to be aware of. PTSD is still one of the most common diagnoses, and it's not just a psychological condition. It's associated with physical health impacts too. In fact, veterans with PTSD are 70% more likely to develop dementia later in life. Many veterans also have a concurrent diagnosis of PTSD and TBI, which complicates treatment and can intensify symptoms like memory loss, emotional dysregulation, and sleep disruption. Military sexual trauma, or MST, affects both men and women. It often goes unreported and leads to long-term mental health challenges, including anxiety, depression, and relationship issues. Moral injury is another key piece. It's not a diagnosable disorder, but it's the psychological pain that comes from doing, witnessing, or failing to prevent something that goes against your core beliefs. Substance use disorders are also common, often as a way to cope with trauma or pain, both physical and emotional. And finally, we need to remember that mental health often presents physically, with chronic pain, GI symptoms, fatigue, or unexplained medical complaints. If we don't recognize the root, we miss the opportunity to truly help. Mental health is part of whole health. As nurses, we're often the first line to notice when something's not right, and the first to ask the questions that matter. Take a moment and look around this room. Now imagine 18 less of you, and tomorrow, 18 fewer. And forward from there. 18 veterans die by suicide every single day. In just 1 week, that's 126 veterans lost, not in combat, but here at home. Quietly. Often unseen. Veterans are 1.5 times more likely to die by suicide than non-veterans. And it's not just a number, it's someone's partner, parent, sibling, friend, someone's battle buddy. You can make a difference. Recognize the signs. Ask the hard questions, connect them to support. Prevent one more casualty of war. When we talk about trauma-informed care in the VA, we're not just talking about best practices, we're talking about essential care. For many veterans, trauma didn't start when they came home. It started during service. Whether it was combat, sexual trauma, loss of fellow service members, or the stress of high-stakes environments, those experiences don't just disappear when the uniform comes off. Recognizing service-related trauma means we approach every veteran with the understanding that their past experiences may affect how they respond to care, communicate, and trust providers. It means we don't assume, we don't judge, and we don't re-traumatize. We create a space that feels safe, respectful, and in their control, because control was something many veterans didn't have during their trauma. Trauma-informed care isn't about asking every detail of what happened. It's about treating every veteran as though something might have, and being the kind of nurse who honors that without needing proof. This slide breaks down how we can put trauma-informed care into practice, especially with veterans who may be carrying invisible wounds. Start by restoring control. Knock before entering and ask, "May I come in?" Something so small can build trust quickly. Always explain what you're doing, especially before invasive or intimate procedures. Even if the patient is sedated. Don't just say, "This will only take a minute." Instead, give clear, respectful steps and ask for permission. Whenever possible, offer choices. Even small ones, like, "Do you want me to check your vitals now or after breakfast?" can give back a sense of agency. Be mindful of your body language and proximity. Avoid hovering or touching without warning. Many veterans associate close, sudden contact with past trauma. If a patient becomes emotional, withdrawn, or even refuses care, don't take it personally. It may be a protective response. Give space, validate feelings, and return when they're ready. These techniques aren't about being soft, they're about being safe. Trauma-informed care protects our veterans and strengthens the therapeutic relationship. Veterans and their families take great pride in being resilient. They've been trained to push through adversity, to stay mission-ready, and to never show weakness. While that strength is admirable, it can sometimes become a barrier, especially when it comes to asking for help, expressing emotional needs, or accepting a change in goals of care. This becomes especially important when we're navigating end-of-life discussions or comfort care. For some veterans, choosing not to pursue aggressive treatment can feel like surrender, like leaving someone behind on the battlefield. As we touched on earlier, that military value of no man left behind runs deep. And for some, comfort care might feel like giving up. So our communication needs to be sensitive, patient, and intentional. We need to reframe the conversation, not as quitting, but as another form of courage, choosing peace, honoring dignity, and making space for quality of life. Resiliency isn't about pushing through at all costs. It's also about knowing when to rest, when to heal, and when to allow others to serve you. As we come to the end of this presentation, I want to ask you to take a moment and reflect. What does being a nurse mean to you? For me, being a nurse means more than just clinical skill. It's about showing up with presence, with purpose, and with heart. Our veterans have already given so much to this country. Many carry wounds we can't see, and some may never share their full story. But every time we walk into their room, we have the chance to offer dignity, respect, and healing. Caring for veterans isn't just a job, it's a privilege. And it's our responsibility to make sure the care we give reflects the sacrifice they made. Let's commit to being the kind of nurses our veterans deserve. Let's be present. Let's be compassionate. And let's never forget the honor of serving those who have served. This is where it all comes together. Veterans are more likely to avoid healthcare, often because of past experiences, mistrust, or simply feeling misunderstood. But we can change that. Small things, like acknowledging their service, asking about their military background, or just showing up with respect, build trust. And that trust saves lives. You make a difference. Every interaction you have with a veteran is a chance to change their experience, maybe even shift their perception of healthcare entirely. So, the next time you step into a room, remember, you are more than just a nurse. You are a veteran's nurse. Let's own that privilege, and let's serve them as they've served us. Thank you for your time and your attention. I hope you learned something from today's presentation.